Okay, so this is Mrs. Roberts again. We're starting on chapter 3 in the Davis Advantage book. This is conception and development of the embryo and fetus. Okay. So as you remember, our normal female has 46 XX chromosomes and our normal male has 46 XY chromosomes. Okay. That determines the sex of the embryo. Our gestational age lasts from 259 to 287 days. And these are just pictures over here of the ones in your book. Okay? And it explains the sperm and the eggs and 22 from each. And it goes into 22, 22. You get a male, 22, 22X, 22Y. So the male, the man, determines the sex of the baby. And then if he has 22X, and then with 22X, that's a female. So it's the male that determines the sex. Then you have the different phenotypes, and that's the different eye colors, hair colors, and then we start talking about the different disease inheritance. So there's all kinds of issues, chromosomal abnormalities from different mutations. I want you to look on page 65, and we're going to talk about the different process of fertilization. Okay, so here, same picture over here on the left is the process of the fertilization. Okay, so this first little snippet is a wink and lollipop. Okay, so transportation of the gametes must occur to allow the oocyte and the sperm to meet. Most often, this meeting place takes place in the ampulla portion of the fallopian tube. So this is the outer third of the fallopian tube. Okay, and I'll show you a different picture here. So the outer third. Fertilization, and it happens out here. Okay. So wink and lollipop again. Fertilization occurs in the outer third of the fallopian tube. Okay. Then we talk about on page 66 the process of implantation and placental development. Implantation begins at the trophoblast cells that invade the endometrium. Okay, so that is at the, let's see, third paragraph down. Right here. Okay, so another wink and lollipop. Okay. So implantation begins at the trophoblast cells, and they invade the endometrium. By the 10th day after fertilization, nidation, which is the implantation of the fertilized ovum into the endometrial lining of the uterine wall, has occurred, and the blastocyst is buried beneath the endometrial surface. Okay, so that's when this comes all the way down, blastocyst, and it implants right here into that endometrial lining that we talked about a while ago when I was showing you the female anatomy. Okay, and then let's talk about the development of the embryo. Okay, so you have the yolk sac. All right, in the yolk sac is the amnion. That's the thick amniotic sac around the embryo and fetus. So your amniotic sac, okay, and we know amniotic fluid and fetus is inside that amnion, right? The amniotic sac, okay? There's something important here. the origin and function of the umbilical cord. So, another wink and lollipop is that the vessels contract to form 2 arteries and 1 vein in the umbilical cord. Okay, so there's 2 arteries and 1 vein. And the thing about fetuses is their blood is the opposite of ours as adults, or as live, not in the womb humans. Okay, so the 2 arteries carry deoxygenated blood, and the 1 vein carries the oxygenated blood. So arteries in a fetus carry deoxygenated, veins carry oxygenated. Okay, our umbilical cord is made of Wharton's jelly, so it's very like a jelly. If you've ever seen a jellyfish, that gel-like tissue, that's how the umbilical cord feels. Very juicy and gooey feeling. So if you've ever seen one, you know what I'm talking about. All right, and this is just talking about some more fetal development overview. Nothing that is too important. I mean, it's in your book, so just some little handouts I thought you could view. It's hard to see, but it says amniotic fluid's usually 800 to 1,000 milliliters at term. If it's less than 500, it's oligohydramnios. If it's over 1,000, it's polyhydramnios, and we'll talk about that later. Okay. On page 68, it's talking about again the blood traveling in a unique way. Okay, so we talked about the deoxygenated being in the arteries and the oxygenated being in the 1 vein, right? But also it's a different concept with how the blood actually circulates. Okay, we have what's called a ductus venosus, a foramen-ovale, and a ductus arteriosus. And you can read through this, just be familiar with those terms. We'll talk more about that later. But the fetal circulation is definitely different. You can see it here. So the ductus venosus is from the portal vein of the liver, and it goes all the way over to what is our umbilical vein. Okay, it goes up to the heart, the pulmonary veins, through our inferior vena cava, and then we have a ductus arteriosus, which is our opening to the aortic arch, and then we have our ductus venosus, or foramen-ovale, open here, and then our ductus venosus open down here. Okay, but we'll talk more about that specifically later on. This is just a picture of the placenta and umbilical cord, not unlike this was in your book, and this one is in your book. Okay, so let's look at page 70. So page 70 is talking about the embryonic period. Okay, so wink and lollipop. For wink 1, you're going to need to know, like we talked about a while ago, that fertilization, where it occurs in the outer third portion of the uterine tube. Okay, outer third portion, the ampulla portion of the uterine fallopian tube. Okay, then let's look at this optimizing outcomes. Another wink and lollipop is this information here. So to prevent neural tube defects, we suggest that a woman take 0.4 to 0.8 milligrams of folic acid daily to reduce the incidences of neural tube defects, such as spina bifida. I've never known anybody to overdose on folic acid, so I always advise patients to take 1 milligram. Okay, it's not going to hurt them, but this is for anybody in childbearing ages. So if you are having sex and you have a uterus that's functioning, then you can get pregnant. So even though you may not want to be pregnant, you can get pregnant if you're having sex. So, and if you have all the parts and the age. So you need to be taking folic acid, because if you get pregnant, the most important time for those neural tube defects to happen is in that first trimester, of course, right? So if you find out late that you're pregnant, later on, you've missed the opportunity to protect your fetus from neural tube defects if you're not already taking folic acid. So it's very, very important, okay? Then it goes on to talk about the fetal periods, the different weeks. You can read through that. Same picture over here. This is a 4-week gestation, about 28 days. You can already see the buds present. It's amazing how fast a fetus develops. And they have the different ectoderm, mesoderm, and endoderm layers. Okay. 9 weeks, 9 to 12, 13 to 16. So you see at week 8 how distinct this fetus looks to a human. Okay, it is a human. Okay, has a very human appearance. It is a human, and this is only 8 weeks pregnant. So 2 months, less than 2 months. Okay. Tables 3 and 4. So table 3 is talking about what characteristics you would see. So make sure that you read through this, okay? And they're over here too, just a smaller version. And then teratogenic exposure, things that can be detrimental to a fetus, okay? Medication, substance abuse, anything. So the best thing to take during pregnancy is nothing, especially that first trimester, okay? Table 3-4 is the different categories, A, B, C, D, and X. Controlled studies say that category A is safe. Category X is fetal risk and congenital anomalies, okay? This is just different milestones here. There's an article talking about maternal mortality, and I'll pull it up here so you can see where they occur. And it's just talking about how the low-income countries produce more maternal deaths than high-income countries. Okay, it's sad, but it is true. And then different milestones, of course. So let's get back over here. There is the mention of alcohol. This is on page 74 in your book. Alcohol is one of the most potent teratogens known for during pregnancy. Okay, there's an article I'm going to drag over, and this is just talking about how alcohol, smoking, and drugs during pregnancy there's guidelines, and the guidelines say no amount of alcohol is good. Not one glass of wine, not one beer, not one drink. Okay, you can have fetal alcohol syndrome. You can have premature birth, low birth weight from smoking and drinking, illegal drugs, of course. Your babies go through withdrawals. It's horrible, horrible. Okay. And then there's another article here that I wanted to share. And this one came out, it's not very, very old, in November of 22. The woman thought that she was okay during her second pregnancy having a glass of wine or two. Okay, she admitted to drinking some wine during her pregnancy a few times, and it cost her baby boy's normalcy. Okay, she thought he was healthy and normal, and then he started developing issues. Okay, she was devastated. She, just felt truly guilty, of course. A lot of brain damage that they noticed, cerebral palsy they noticed. So she is now an advocate for no alcohol during pregnancy. Okay. And here's a short little clip I want you to watch as well.
Alcohol can affect your baby at any stage of pregnancy, even in small amounts. In the earlier stages of pregnancy, alcohol can damage the cells that go on to form the placenta and developing baby. The baby's brain starts developing very early and continues developing throughout pregnancy. Exposure to alcohol can permanently affect the brain's structure and function. Alcohol can also disrupt the development of the developing baby's heart, kidneys, and lungs. This damage can result in physical, behavioural, and cognitive problems known as fetal alcohol spectrum disorder, FASD, a lifelong disability. Support is available if you need help to have an alcohol-free pregnancy. Speak with your doctor, midwife, or obstetrician who can help you with your individual situation and provide you with specific advice. For support and to find out more, visit everymomentmatters.org.au.
So it's very important to educate your patients not to drink anything, any type of alcohol, no tobacco, no, even limit their caffeine. I know that's hard, but especially those strong monster drinks, any kind of energy drinks at all, just limit those, because that's a stimulus for the baby, for that fetus, and it can actually cause issues. Okay, I want you to take note of the crack and cocaine paragraph here. It can cause, and this is a big one, abruptio placentae. Okay, placental abortion, spontaneous abortions, placental abortion, stillbirth, IUGR, which is intrauterine growth restriction, of course, all kinds of things. I had a patient one time that came in her early 20s with her 12th pregnancy, 12. She was 22, 23 years old, and she didn't have custody of any of the ones that survived. She was addicted to cocaine. She was abrupting, so they did an emergency C-section at about 18 weeks, and it was because she has a cocaine addiction. So she lost a baby. She lost all of her kids because of her addiction, but this could have very well killed her if she didn't get to the hospital in time, because she would have hemorrhaged to death from the eruption. So, but you need to know that cocaine causes abruptio placentae, and we'll talk more about that later as well. Big risk factors, though. We just watched these videos on the risk factors. Torch infections mentioned on page 75. We'll talk more about this in chapter 6. But it's a group of agents that can infect the fetus or the newborn. It's toxoplasmosis, other transplacental infections, rubella virus, cytomegalovirus, CMV, and herpes simplex virus. That's what TORCH stands for. Okay, and you'll see that here. Okay, but we'll talk more about that later on. Teratogenic drugs, you can read through those. Pesticides, even making sure that they wash fruits and vegetables. We'll talk about that stuff as well. And then it goes through the different torch infections. Okay, but we'll talk more about that in chapter 6. You can read through that though. And then here's the box that explains it all. pulled this from chapter 5, but it's just talking about the teratogenic medications. One of these is thalidomide. Okay, thalidomide is a drug that caused fatal birth defects, some fatal and some shortened limbs, bone abscences. It was a drug that was given in Europe and some in America for nausea, vomiting, hyperemesis during the first trimester, and it caused teratogenic effects. It was given in the 60s, 50s, 60s, and early 70s. Of course, it's category X and it's banned now from pregnancy. But there's other ones: warfarin, acetylphenone, phenytoin, and lithium. Okay, but thalidomide I wanted to talk to you about because this is what happened. Okay, these babies were born with what they called at the time flippers. Short arms, shortened legs, no bones, and these babies, dealt with this the rest of their lives. 10,000 miscarriages and infant death happened in the UK. This table is on page 79 in your book. And this is just the chromosomal syndrome. So you have the trisomy 21, which is Down syndrome, trisomy 18, Edwards syndrome, trisomy 13, Pateau, Klinefelter, that happens in males, and Turner syndrome that happens in females. And you can see what happens, the characteristics and the lab values. Okay, very interesting. They test for these when they do the metabolic screening at birth, the PKU, where you put the little dots of blood on a card, you mail it off to the state in Atlanta. The lab up there runs all the tests, and it's a required test for any baby born in the state of Georgia. They mail the results back to the parents and to the pediatrician. But they test for like over almost 40 different congenital anomalies. But these are some of the ones. Okay. Multifetal pregnancy. Let's talk about that before we go to chapter 4. A multifetal pregnancy. So you have the division that happens in the first 72 hours of fertilization. Okay. So you have monozygotic twins that share a placenta and a chorion. Okay. And 2 amnions. And then you have the dizygotic twins that have 2 placentas, 2 chorions, and 2 amnions. Okay, so they have their own thing going on. Over here, they share that amnion sac. Sometimes they have their own chorion sac. Sometimes they're right together. But they share a placenta, and they have their own cord. Okay, but that's just an example of a multifetal pregnancy. Okay. And then it talks about the different karyotypes. You can read through that, genetic diseases. Okay, so that's it for chapter 3. Chapter 4, physiological and psychological changes during pregnancy, which is a lot. All right, so let's talk about that. We're going to start on page 88. So physiological adaptations during pregnancy. Our uterus. Okay, so our uterus is a muscle, right? We know it grows, stretches, doesn't actually grow, but stretches when the baby, the fetus, is in the womb. Okay, so it provides a home for our fetus to grow. All right. And this is a picture that's in your book, so let me scroll on down. It talks about the different terms. So fundus, remember me saying that's the top of your uterus. That's a term that you're going to hear and that you need to know. You're going to be trying to feel the fundus as it involution happens after delivery when we go to clinical. Okay, lightening occurs at the end of the trimester. Third trimester, and that's when the baby drops. So you've heard people say, "Oh, your baby's dropped," or "You look like you've dropped." That's the lightning term, okay? Braxton Hicks are irregular, painless contractions. Don't think that that's real labor, okay? These are just pain. This is your body's way of getting ready for the real contractions, okay? Then our cervix. We have what's called a Chadwick sign and a Goodell sign. So let's look at this picture here first, and then we'll look at the cervix, okay? So at about 12 weeks, we have our symphysis pubis, okay? So here, I know it's pointing to here, and that's what that is, but about our symphysis pubis here is 12 weeks gestation, okay? So we feel that bony prominence at our pubic area, and that's about 12 weeks gestation when we're measuring. At about 20 weeks is at our umbilicus, and 36 to 40 weeks is at our xiphoid process, okay? That's some things that you need to know. So 12 weeks symphysis pubis, 20 weeks umbilicus, and 36 to 40 weeks is our xiphoid process, okay? All right, so now let's look at the Chadwick sign, and I have a better picture of it over here, okay? I wish I could blow this up to make it a little bit bigger. Let's see if I can do this. There we go. All right, so the events in the first trimesters, you have what's called the Chadwick sign, and that's when the cervix is visibly like a blue color, okay? Then you have Auslander, Goodell sign, which is the softening of the cervix, Piscakis, and Hagar sign. So the ones I want you to know are the Chadwick sign, which makes the cervix blue, and then the Goodell sign, which is the softening of the cervix, okay? You see how it's kind of a blue tinge right here? So make sure you understand that. All right, the vagina and vulva, okay? So you have some leukorrhea, which is the white discharge that happens from hormones during pregnancy. Another term. Increased mucus. And then you have a wink and lollipop, okay? So your wink and lollipop here is how your vaginal environment is very, very susceptible to Candida albicans, so the yeast infection, okay? So it creates an environment where yeast like to grow. Warm, wet, dark places, okay? Wink and lollipop. Ovaries, your LH luteinizing hormones are secreted from your pituitary gland, and then you have your follicle stimulating hormone, so your FSH, and we'll talk more about those later on, but it has to do too with the baby's fetal lung development, the fetus lung development, okay? So then you have breast. You have striae gravidarum, which are stretch marks, and sometimes you can see these on the breast as well. This is the abdomen with the striae gravidarum, okay? These are just different labs, diagnostics, cardiac output. So during pregnancy, we know that our cardiac output increases, okay? So about 20 to 24 weeks gestation, about 30%, 30 to actually 50%, it has increased already from pre-pregnancy levels. So your body produces about another liter of blood during pregnancy. That's pretty impressive. So that's why at delivery, it's okay for a vaginal delivered patient to lose 500 milliliters of blood and 1,000 for a C-section. Okay, and we'll talk about that later. That's something you do need to know, but we'll cover that a little bit later. But it's because there's 30 to 50% more blood volume during the pregnancy. That's why it's okay, because it's been overproduced, and so that's why we can lose it and hopefully not become anemic. Okay. Page 91 is just talking about these different labs and the different metabolic changes. So they're here, so you can read through those. This is what we want our normal female to have. This is our value for pregnancy. So you see it does drop a little bit, but we still want it, above 10. That's our magic number, is we want it to be at least above 10. All right, so let's talk about some different problems. You can have some gingivitis during pregnancy, early onset of gingivitis, so make sure that you take care of your teeth. Tell your patients to take care of your teeth during pregnancy, okay, because they can get that gingival hypertrophy. You see how the gums are going over the teeth, okay? This can happen during the first trimester. Hyperemesis gravidarum, that's where you are sick, like it's nausea, vomiting during pregnancy. Pyrosis is the heartburn. So please understand that if a woman has a baby with a lot of hair, it's not because she had heartburn. That's a wives' tale. That is not true. It has nothing to do with it. Pyrosis is the heartburn because at the end of the trimester, progesterone on the smooth muscle is relaxed the esophagus. The baby is pushed up, the fetus is pushed up, and so the food cannot digest as well because there's no room, because the fetus is taking up the room. So you have gastroparesis happen. Okay, so the gastroparesis is where the food sits in the stomach, and then your stomach acid overproduces, and that's what causes the heartburn. It has nothing to do with the baby's hair. Okay? All right. Hemorrhoids. They're the friend that just stays around forever unless you have a hemorrhoidectomy. These are varicose veins of your large intestine that come out of the rectum and anus at times. Okay, you can have internal hemorrhoids, you can have external hemorrhoids, but they're usually your friend for life. Urinary system. So another winking lollipop here in this paragraph on page 93. So your first trimester, women all usually have a urinary urgency during the first trimester, okay? Getting up at night during the first trimester. Second trimester, it gets better, often relieved as the uterus grows and moves into the abdomen. And then they get that pressure relief off the bladder, and then, of course, returns during your third trimester where your baby starts growing, the fetus starts growing, and you don't have any room. Okay, so winking lollipop there. Page 95. Let's talk about the integumentary system. So this is what these pictures are over here. So you have a linea nigra is what it's called. Linea nigra. It's from hormones that happen during pregnancy. Okay, so it's the line linea nigra, and then you have chloasma, which is your mask of pregnancy. Okay, and this is because of hormones in pregnancy. So you see how they have the little butterfly mask over it. Okay, not unlike a lupus mask, but it's just during pregnancy. Okay, it's hyperpigmentation. And of course the stria gravidarum, it's the stretch marks, right? Signs of pregnancy. So, on page 96, lots of information you need to know there. Different signs of pregnancy. So, we have presumptive signs, probable signs, and positive signs. Okay? You need to know the difference. And there's a chart that is a wink and lollipop. I'll show you in just a second. Under presumptive signs, another wink and lollipop is this. Wink and lollipop. Perception of fetal movement quickening occurs during the second trimester. The sensation of fetal movement may also result from flatus, peristalsis, and abdominal muscle contractions. Okay? So, you cannot think that you're pregnant just because you feel like you feel a baby move inside of you. Okay? It could just truly be gas or stomach cramps. Okay? So know that. This usually happens between 4 and 5 months. 4 and 5 months. Okay? Alright. And then it starts talking about the probable signs and positive signs. But this chart here, this whole chart, is a wink and lollipop. You need to know this chart. Okay? Wink and lollipop. Know the presumptive signs, the probable signs, and the positive signs. Know the signs and symptoms, and know the alternative conditions that can be the reason they have these issues. Okay? There's just a little blip over here. Some things I found. Little article, pictures, signs of pregnancy, presumptive, probable, and positive, if this helps you. To remember those, there's some acronyms there with different definitions. So you can read through those. Now let's talk about establishing the estimated date of birth. You have early term, which is between 37 and 38 and 6. Full term, 39 to 40 and 6. Late term, 41 to 41 and 6. And post term, this is after 42 weeks. Okay? We use a rule called Nigel's rule to give us the estimated date of birth, or the EDD, estimated date of delivery. Okay? It used to be EDC, which is estimated date of confinement. But it's based on your last menstrual period, assuming that you have a normal period, normal 28-day cycle. Okay? So, we're going to practice some of these in class. Alright? So, you just need to know how to calculate Nigel's rule. Right there it is. Okay? And then it's also listed here. So to use Nigel's rule, you add 7 days and subtract 3 months from the last menstrual period date, and then add a year. Okay? So, if you had the last menstrual period of June the 8th, 2014, you add 7 days. That would be June the 15th. You subtract 3 months, which will be March the 15th, and then you add a year. So if her last menstrual period was June the 8th, her due date would be March the 15th. Okay? We'll practice some of these in class. But that is a wink and lollipop. You need to know it. And this just explains Nigel's rule again. This is a gestational wheel that we use as labor and delivery nurses. I used to keep one in my pocket for years and years and years, and I have my favorite one that I always have with me. But this is just a quick way of doing Nigel's rule. You get their L&P, line it up on the wheel, and it does the math for you. Okay, add the 7 days, subtracting 3 months, and adding the year, and it gives you the arrow as to when her due date is. Okay? Discomforts. So I want you to read through these common discomforts of each trimester during pregnancy. So of course you got the nausea, vomiting, the heartburn, hemorrhoids, fatigue. Then that, especially the last trimester, you can get that nasal kind of stuffiness. Okay, so you can read through those. Alright, so let's look at page 104. Table 4.4. Okay? So, maternal task of pregnancy. So, binding in. I want you to know, we can lollipop this acceptance of pregnancy. So, self and maternal role binding in. Okay? So, second trimester, this is kind of important, okay? And this happens between 4 and 5 months, okay? So, 4 and 5 months, second trimester, with sensation that the baby's moving, or the quickening, the baby movement, not to be mistaken with lightning, where the baby drops, but quickening is where the baby's moving. Lightning is where the baby drops and settles into the pelvis, okay? She becomes aware that the child is a separate entity. She's filled with wonder and perhaps concern over the changes that are taking place, and the fetus becomes her major focus. She experiences feelings of love and attachment and enjoys fantasizing about her new role. So, be familiar with that. Wink and lollipop. And then we'll talk about this GT PAL in a little bit. It's in the next chapter. So we'll come back to that. And this is talking about the different changes. And then we will start chapter 5.